Hello, I am Mohammed, one of the MSN FNP student at Franklin University. I am going to present my discussion on one of my geriatric patients. I have seen in the clinic who have experienced a lot of chronic medical conditions and is encouraged to have the end of life care discussion to take decisions about terminal medical care. I thought she will be a great patient to present to you all to help to show you about the importance of end of life care discussion. A little overview about my patients. She is a 96 years old female who has history of COPD, CHF, IBD, hypertension, hyperlipidemia with history of stroke. She presented to the clinic with complaint of left side chest pain from the rib cage area with worsening shortness of breath for last several days. She reported that her oxygen saturation was almost in a lower 80% with her PRN 1 to 2 liters of oxygen use, which was her baseline. She had to increase her oxygen up to 3 liters. Even with that, her saturation of oxygen was remain in between 87 to 90% most of the times of the day. She has multiple hospitalization history within the last 1 year with almost same issues over and over with exacerbation of her chronic heart failure. Patient was retired a chemical technician, worked for almost 40 years. She had a happy family life with husband for about 61 years and 3 children. Patient lives at home by herself now, but her 3 children go to her house almost every day to visit her and helps with her errands. She was a former smoker who smoked for about 45 years and without any history of alcohol intake or any other drug usage. With her progressive declination of health condition, she was having difficulties even to walk around her home without producing any physical sign and symptom. Her first heart physical attack happened about 1.5 years ago while she was cleaning with starting having a rib cage pain. She was seen at the clinic and was sent home with Tylenol with lidocaine patch. She started worsened with chronic heart failure with COPD exacerbation. Since then, she tried several prescriptions of increased dosage of Lasix, antibiotic for COPD exacerbation, steroid, and some pain medications. At the same point, she was sent to the hospital and diagnosed with pneumonia with AKI and leading to multi-organ failure at the hospital. She experienced sepsis and was intubated. After about a week, her tube was taken out and having a difficulty in maintaining a regular healthy life. We have discussed a couple of things about end-of-life care decision-making process. She already made a living will with healthcare proxy, who is her elder daughter, who live very close from her home. She also helps her with daily living chores. Patient said she knew that she will respect her desires about medical decision making. In any life-ending medical condition happen to her, she was very understanding about the terminal illness and was really open on discussing her end-of-life care plan, and she already had a lot of conversation with her children where her family was very supportive and very respectful about the decisions. The daughter did state that it is very hard to see the rapid worsening condition of her mother. The clinicians did kind of pre-discussion with them about the upcoming terminal disease process based on her physical progression at her age. They describe it is very clearly about life expectancy with worsening terminal illnesses. The daughter was is in the denial state at the very beginning of the discussion because her mother was active in her life, but she would respect any of her mother's end of life care decision as far as her mother's wishes was informed, and everything will be in place documentation wise. As I stated, patient had her living will, POA, which is healthcare proxy, all completed with her attorney in the last year. She said she did this because she really did not want her family to feel like they had to make any of those decisions, and she wanted them to be in place in case something happened to her in near future. We discussed about patient's disease, the outcomes and goals along with her plans, and I just wanted to know that what kind of thoughts lead her to make these decisions. She said she wanted to pursue all treatments that would allow her to move forward to have a healthy life, to spend some more time with her family. But she did not want to have any kind of CPR or any other type of invasive procedures if her heart stops or no intubation in brain death situation. She thinks it will be a burden to her family to keep her alive in that way. She was not able to take care of herself or prefer her normal daily life activities. She does not want to go for any invasive life saving intervention. I told her that patients sometimes can come back with CPR and go on from there. She stated that even though it is kind of a gray area, she does not want any invasive treatments which will not make her go back to normal life again, and definitely not if she was considered brain dead. She did not want to be kept alive. A couple of barriers that the patient stated it was very hard for her to accept the progressive declination of her health condition, which except that she had to make this decision. She want a thorough discussion, and so she went through a lot of anxiety and depression with those decision making. She had lived a fantastic life with her husband and children where she served them the best. She got the privilege to be honored and satisfied from most of the people she met so far in her life. She was very thankful to God for giving her such a better and happy life. She said it was more about protecting her family and spending the time that she does have with her family and trying to minimize the barriers or the burden she would going to create for them by being invasively treated. She mentioned that her living will has the description of her desires, even about her cremation process. She had everything already set up for her family so that they would not have to make any decision, and everything was kind of taken care of. As far as advance directives, she had them completed after discussing with her family prior to the meeting with her attorney, so that they all would be aware of her wills. There was no input from any other family members that would prevent any issue amongst the family after her passing. She made her decisions from her previous hospitalization stays, like where she allowed all her previous hospitalization, allowed all the needed medical treatment, diagnostic testings, etc. When I did have this discussion with her, she was at full capacity. She was very much with it for all our decision with plans. She was fully aware of her short lifespan with her worsening conditions. I did discuss about palliative care with her. I did talk about Karnofsky performance scale to find out her ambulation alertness, self-care level, patient with a lower point where they have to use a walker or they cannot ambulate, they have significant evidence of disease. With her situation, if she had to use high flow oxygen at all the time, not able to ambulate, related to COPD or CHF exacerbation, she would be given a shorter period of expected lifetime. This patient was moderately scored 6 to medium, as she was ambulatory despite of her weakness, frequent falls with other problems. I just wanted to conclude with how much this patient opened my eyes to the importance of end of life care discussions and the decision making process, especially for the patient with terminal illnesses. As a provider, I am going to encourage patients to complete advance directives along with other decision making so that they can open their eyes to the things that they could see what might happen at any moment for patients with chronic conditions. If all these legal documents are not in place, it is hard to know patients' last wishes about medical interventions at the end of life care situation. Thank you so much for watching and listening to my presentation. Thank you again.